Good morning. My name is Michael Tidd with Healthcare Synergy, and we'll be discussing clinical review and coding this morning. Wanted to alert you that there is a few poll questions that we presented to get an idea of the target audience and to be able to get an understanding of what's important to you and what your experience and such is. No, that's not what I wanted. So let's go and begin with the webinar. My experience with Healthcare Synergy is that I'm a licensed nurse. I'm certified both in the Oasis coding as well as Oasis. Synergy decided that several years ago they added some additional audits or checks messages within the Synergy software, specifically relating to the Oasis validation rules that CMS does. And a lot of people started asking questions specifically about what manifestation codes are in the software because that was a new error message to them. So Synergy pushed me on the roll to getting Oasis certified, getting coding certified so that we would be better able to answer some of your questions. And that's kind of where we're at now. This is our first webinar talking about coding functionality and Oasis services that we do. And being at the end of the year 2012, we wanted to make sure clients were aware that that is a service that we provide. So the first part of this webinar is going to be discussing the CT services, clinical technology services that Synergy offers to its clients, and giving you an understanding of what that is, how that might work for your agency if you're interested in it. But I didn't want this really to be a sales presentation. I wanted it to be more educational for you. So towards the end, we're going to be speaking about some of the specific Oasis-based questions that are frequently missed based on the assessment and the guidance information, talking about where you can get resources for Oasis and coding education if you don't already have those, as well as talking a little bit about coding and manifestation codes, because we find that there's a large number of clients that use our services that don't fully understand how the Oasis questions should be answered. The clinicians maybe don't have training in those, or the coders don't understand the manifestation coding functionality requirements towards the coding guidelines. So that's one of the things that we wanted to be able to roll out. So what we're going to be discussing is the clinical review and what we do, and then be able to move from there into some of the Oasis information, and then move into the actual coding. If you have questions, you're welcome to chat on the side. Be able to, in the GoToWebinar, type in your questions, and I'll open that up so that I can kind of monitor and see what those responses may be. And then towards the end, we'll open up for any questions that you may have, responding to either the chat itself, or if my technical advisor in this GoToWebinar can stay and monitor us, then we'll actually open it up possibly to some audio questions that I can respond to as well. So the coding review services, what it offers is the ability for agencies to outsource or outstaff their review process or serve as a double check to their existing services. We have a variety of clients that do both, but specifically what it does is it looks at the comprehensive assessment, not just your Oasis questions, but it looks to make sure that the overall comprehensive clinical questions that are integrated in your Oasis assessment agree with the questions that are answered as far as the Oasis scores. We also look at the coding, taking a peek at those to make sure that they're as accurate as possible. They give you the best reimbursement as possible without upcoding, and that they're accurate with the information that's presented in the documentation. So I wanted to start with a couple quotes of our longtime clients. This is a service that we've had available since November of 2009, I believe, and we rolled it out with a few sample clients to kind of get an idea of the benefit of the service, as well as how much time it took, and to get an idea of to set pricing. So this is our very first client, Sadan Lagatua. She's owner of Adobe Home Care in Salinas, Northern California, and her quote was that she found the resources priceless. She used to stay up reviewing every single Oasis and doing the coding for that until late into the evening, sometimes early morning, and then she'd turn around the next day and start it again. So when we asked her to help us set a price, how valuable that was to her, she gave us a quote that didn't really help in setting the price. She said it was absolutely priceless. And we've had a few other people contact us back saying that that was their exact sentiments as well. The second quote comes from Ken Ehrman with RX Staffing in Sacramento, California. And his is more a broad overview of what the service is and the benefits that he sees in it. Because part of the goal is to make sure that your charts are defendable if they ever get audited, that they're accurate and complete. Now obviously the chart is more than just the assessment. The chart is all the visit notes as well. And we've slowly been adding visit note functionality to that as well, if that's beneficial. So what I was saying is that the clinical technology services has been helping some clients, and this is the second quote from Ken Ehrman, and his feeling is what our hope is that it provides a guarantee of quality as well as improves the care for the patients, improves the reimbursement to the agency, and it gives them an independent oversight of their process. So I'll leave that up there for another minute for you guys to read that, just to get an idea. One, touting the worth that I see in the service, but the second is trying to get your attention, so you'll pay attention through the rest of the slide, presentation of why it's essential. Again, I don't like the idea that I'm selling this service to you. I like to think that I at Synergy am more of an educator of what the services Synergy offers are, and then you obviously know what's best for your agency, what your struggles are, and how you want to improve those if needed. So the service may not be helpful to anybody because you have a very qualified staffing helping you. So with that said, let's go further because the slides are available. Towards the very end, I have my email address. You can email me with questions as well. So the reason for offering this service is that there's a lot of agencies that are concerned about audits, ADRs, and reviews of their data, and that they'll be found lacking when it comes time to provide those questions if these assessments get surveyed. There's a lot of agencies, obviously, that want to maximize their reimbursement without opening up potential risks. So that's one of the services that benefits of the service. And then we also provide an opportunity for agencies to look at every single chart, every single assessment, and be able to review that because there's a lot of times even your experienced clinicians may miss something periodically. So that's one of the benefits of agency or to the agency. The special features is that we have licensed clinicians completing the work. We don't have anybody working with us that's not a licensed clinician. They're all certified in Oasis as well as coding. And we use the documentation that's available looking at the comprehensive Oasis assessment, looking at the H&P, the history and physical of the patient to get an idea of what their past history is, looking to see if there's any comorbidities that should be coded, or does the assessment reflect those comorbidities, as well as any MD orders that you may have already prepared, having been out and seen the patient and based on their treatment. So it's more than just the comprehensive or more than just the Oasis questions. We really want to make sure you have a sound documentation. The comprehensive assessment, we feel, prevents loss of Medicare reimbursement dollars to yourself, being able to maximize that episode reimbursement. Specifically, we're very focused on looking at the orders and goals that you put on the intervention as part of your comprehensive assessment and being able to ensure that you're not upcoding. Upcoding occurs when you place a diagnosis on the care plan so that you can get paid for it, being a Casemix diagnosis or a payment diagnosis, and then you don't do anything as far as interventions or orders with that. That leaves you open to denial of the claim or downcoding as a review process of the review and just denying that particular diagnosis because it's something you assessed at the initial assessment, but you never actually carried out any interventions for. And then downcoding, it would be just the opposite of that. Downcoding is comorbidities that aren't placed on the 45 that could generate money and payment for you, either because of lack of knowledge of how to code or lack of review of the H&P and the other documentation. Some clients, some agencies don't put all the appropriate codes on, and therefore their reimbursement isn't as much as possible. And then the last one would be to increase the agency's reimbursement as well as accuracy of the documentation itself. Because, for example, they may have CHF, but you don't have any interventions to monitor for weight gain. You don't have any interventions for breathing exercises and such. The need for the service, why we started it, besides the fact that we had a lot of calls from people that didn't understand what manifestation codes were and such, is that we find that there's a significant lack of training in clinicians. Oasis is not common sense. A lot of new agencies or experienced agencies hire somebody that says, yes, I've done the Oasis before, and sometimes they assume that they have training in the documentation. When I say Oasis isn't common sense, when you pick up an Oasis question, one of the ones we'll talk later is MU 1200. If you just simply read the question without understanding the intent of the question that CMS had, or being able to answer, understand the different Q&As that we'll talk about behind that, then you can answer the question totally incorrectly. Oasis, being a standardized document, is designed to fairly judge all patients across the country. And as a result of that, they'll ask specific questions that won't follow common sense with what your clinical training has been. It's essential that your clinicians understand the Oasis, or your QA staff if you're doing it in site, so that you can point out those inconsistencies with clinical knowledge and practice with regard to how the Oasis questions are based. And we'll talk a little bit more about those as we go on. CMS has questions and answers that have been asked based on how the Oasis question should answer or should be answered. Specifically, every quarter there are updates to those. They're released through a company called Oasis Answers, and I have a link for those, I believe, in the next couple slides, where you can monitor those. And if your clinicians that are completing your Oasis aren't looking at those or aren't aware of those, then, and your QA staff isn't either, then you have a significant issue at your agency, because you could be losing a significant amount of money based on how those questions are answered. And we'll talk more about that when we get into ADL questions. Codings, coding copies of the H&P. What I mean by that is there's a lot of agencies that we have signed up as clients that take the H&P documentation, and when they do their coding, they simply copy those codes directly over onto their payment diagnosis codes 1020 and 1022 without digging into those to see what the manifestation coding requirements are, what the coding guidelines are. And as a result, they put themselves at risk for further scrutiny, because oftentimes the hospital facilities are using codes that are acute care codes that cannot be used in home health, such as a CVA 436 code or a fracture code, and they're putting that as their 1020, 1022 code, which isn't an allowable scenario in home health. But they're copying those codes. Now, you won't get a rejection from the Oasis validations in Synergy, because Synergy doesn't validate those codes and CMS doesn't validate those codes. But what will occur is you'll get a survey or an auditor that will look at that and say you can't use that code because you're not following the coding guidelines. The coding guidelines themselves are released every couple years, some years every year. This year there didn't happen to be any coding guidelines changes, but when you download that from the CDC website where they're released, there are 107 pages of that. Now, there's a lot of home health agencies that don't understand the conditions of participation. They don't fully read those. They rely on consultants and so on. Likewise, there's a lot of coders that don't fully understand the coding guidelines. So they open up the book, they find the disease, and they put it down without understanding the guidelines and the rules for using those. And then we find very frequent manifestation coding violations when we're doing that. And we'll talk a little bit more about manifestation codes at the very end of the presentation today. Another benefit of the service is outsourcing staff. It reduces a lot of costs for the agencies because they have reduced benefits. They're no longer paying for benefits when they outsource and they pay per document reviewed. They eliminate vacation issues and scheduling issues of late documentation because the RCT services can continue every day of the year to be able to plug through that for you. They also avoid training costs. As a CT service client, you're not paying for the individual reviewer to go off to a seminar to get Oasis certified or to become coding certified or maintain their certification. For example, when we changed to ICD-10, that's a significant issue that agencies must start looking at if they're not already doing so, budgeting the training hours to send their staff off to ICD-10 training, because it's going to be a totally different process. The coding guidelines are a significant overhaul. And if you're relying on ICD-9 training and you're just going to open up the coding book and start coding, you will have a significant number of issues that you'll have to address and deal with. And then the other side is its fixed costs. We believe there are significant advantages to agencies outsourcing their services for QA and review that far outweigh the cost of the service itself. Because when you start looking at the additional Casemix reimbursement that you may obtain, that can offset the service fees. When you look at the other fixed fees that you have that I've got listed on the screen here, then you start realizing there's a benefit to that. Without further saying that, let's continue on. The methodology that we use, or how we do that review, typically consists of point of care. We have clients that are using eClinical Assistant as well as Deviro, or formerly known as SOS, software products. It's an add-on to the Synergy software to be able to capture your documentation electronically. We also have individuals that are submitting paper documents to us. My understanding of the typical Synergy client, and hopefully your poll is going to clarify this maybe, is that the number of clients that are using point of care has increased over the last few years. If you'd asked me 5 years ago, I would say that easily 75 to 80% of our clients were all on paper. I believe that today we have 60 to 65% of our clients still on paper because it's a known method. It has a reduced cost. As far as you don't buy equipment for your nurses, you just pay for the paper. But the paper does have a significant turnaround time because you're getting the documentation in, you're looking at it, doing review, hopefully at least that's occurring, and then you have to track down the clinicians to be able to answer those questions. So the service, while it benefits clients the most when it's an electronic documentation because the clinicians can get that immediately, we do have some clients that are doing paper as well. There's a lot of different options of how you can customize the service. You actually choose which documents you want us to look at. Your choices can be all assessments. You can choose specific Oasis types, such as start of care only, resumption of care, or transfer recertifications. You can choose to send us specific assessments that are difficult cases for you. If you already have a review staff in-house, this may be an option for you that you can, if you have an increase in your referrals that's over what you're able to handle, you can outsource just a few of those charts as needed to make sure that they still get timely review and correction and locked and to speed up your billing process so that it doesn't interfere with your cash flow. You can choose to have us do all insurance companies, or you can select specific insurers. You can choose and say, I only want you to do Medicare. That's what some of our clients do because that's where the significant reimbursement process occurs. And those are typically the Medicare and Medicaid are the ones that require Oasis. There are a significant number of agencies that do an Oasis on every single patient just to prevent the possibility this patient is a Medicare secondary payer and you didn't know that when you started treating the patient. You found out 60 days or 40 days into the treatment that the primary insurer says, nope, they're Medicare, we're not paying a dime, and then you didn't do the Oasis, which is a requirement for Medicare to pay from the start of care. And then you can choose Oasis coding only as an option as well. Honestly, we don't currently have any clients doing coding only, but we did have some requests towards that, so we developed pricing just for coding. But to do a thorough coding job, you really have to look at the entire Oasis assessment, because sometimes there is information in the H&P that is not listed on the codes, and it's not anywhere in the assessment. In that kind of a case, we'll ask you questions on whether that code should be applied. But if we're just doing coding from a coding worksheet that your clinicians may have filled out, there's other comorbidities that might have been left off, and we'll talk about those further into the session here. The other thing that I want to address at this point in time, because we get a lot of questions about it, because a lot of people see the review service as an opportunity to do coding, is the transfers and discharge assessments. There's a lot of people that say, why do I need you to review that? There's no codes on that. And that's a very true question and statement. The benefit of looking at the discharge assessment and the transfer, and this is something that you can easily do at your agency, even if you decide the CT service is beneficial for you, is that the transfer and the discharge are time points that significantly impact your home health scores, your home health compare scores specifically. If you're not already using Home Health Compare as a marketing tool, I would strongly suggest that you look at doing that and be able to tout yourself in the expertise of where you're able to do. If your agency excels at orthopedic knee and hip replacements, and you're one of the best agencies in your area at wound healing, at ambulation skills, and regaining the skills that they've been set back in, by all means use that to increase your referral basis. But it starts with the review process. If your agencies aren't reviewing at the discharge because they think it's just the end of the episode, we're not being paid for it, then you are very, very wrong. The discharge assessment can impact your future income. Now, while it does not affect the episode reimbursement for this particular episode, it can drastically change the perception of your agency from your referral sources as well as from your potential clients. As you probably are aware, your clinicians, your referral sources can refer your agency for services for their patient. But the Medicare beneficiary guidelines put the beneficiary totally in control. They can disregard the reference or referral that the physician makes, and they can go to the Home Health Compare site if they're aware of it, or based on feedback from a friend. They needed services somewhere else, and they really liked the home health agency that their friend went to, so they decided to change from you. So at the point of time, the Home Health Compare is a tremendous tool to increase your potential reimbursement. So that's why it's very beneficial to look at. Now, obviously, if you already have a review process in-house, CT services may not benefit you in that way unless you want to take advantage of outsourcing functionality. So that's why those are offered as options, even though there are no codes there. Every single assessment that you process is essential to the view that your agency has when looked at Medicare and so on. It also has impacts when you do your discharges and your RFA 7 transfer. Your surveyors are seeing that information, and they're looking to say, did you really resolve the whole issue for this patient? So I want to move from there into the Oasis side and give you some information about Oasis so that it's not just total sales, but the Oasis, I strongly feel that accuracy matters, and hopefully I've made that case in discussing the CT services thus far. But what I want to make sure you understand is that the standardized question set that Oasis or CMS has defined in Oasis is to address patients across the country. You may be in Los Angeles, or you may be in Houston, a large metropolitan city. You may be in Pocatello, Idaho, a very small community that serves a lot of rural patients. Your patients may not look the same, may not have the same issues that another home health agency down the street or on the other side of the country has. The Oasis assessment was designed to evenly compare those patients across the country so that regardless of whatever your factors are, it's the same type of assessment being done on the patient, and ultimately they should all have the same process. To be able to answer the Oasis questions accurately, it's a must that you understand, or your clinicians understand, and your QA staff understand the intent of the question. There are areas, and I've got the intent on the MOO 1200 slide that we'll go into, where, like I said, Oasis is not common sense questions. When you look at that, you may be answering something, but if you don't understand the intent, you can be answering that question very incorrectly, and as a result, cost your agency money. You have to understand the questions themselves, the assessment techniques that are available to you. There are a significant number of clinicians that do an assessment strictly as an interview. You're not hiring a patient. You are assessing their needs. And if you do an interview with the patient, then you are not doing a service to your agency or to the patient. The assessment techniques that I'm referencing are specifically in the ADL process. Start the assessment of the patient as soon as you walk into the office. To the patient's home. Do you smell urine? The patients are most likely going to tell you they're not incontinent because they're embarrassed about it. But if you smell urine as soon as you walk in the house, you know there's an incontinence issue. Do you see stains on the sofa or on the chair? Do they have padding there to soak that up to prevent staining? Ask them to do things. Ask them to get you a glass of water and watch their ambulation. You may have had the training, or your clinicians may have had the training of doing that, and if they do, that's fabulous assessment skills that they have. But if you go in and say, well, how do you deal with walking up the stairs, or do you feel you can safely get in the bathtub without seeing them do that, or without observing their ability to safely ambulate into the kitchen and get you a glass of water, or do other processes, watch them walk back from opening the door if that's the case. Also, to continually monitor the question and answers. CMS is continually receiving questions from agencies on how to answer questions in unique scenarios that may have never been asked before, that contradicts or confuses an agency on how they should be answering a question. So the other side is training eliminates guesswork. There are a significant number of clinicians out in the field doing Oasis that look at an ADL question and say, well, this patient really could be a 2, or maybe they're a 3. I'm going to go ahead and pick a 2, or I'm going to pick a 3. If you understand the intent of the question, you understand the Q&A questions, it will be very obvious to you that there is never a situation where it could be this or it could be that. The Oasis intent and Q&A will define that this has to be a 2 or this has to be a 3 if you have proper training in that. So that's my soapbox about getting training on the Oasis so that you can answer it correctly, because the Oasis questions, regardless of the rest of the comprehensive questions, is what determines the Casemix reimbursement for this patient's episode. And if you're not answering those correctly, your agency could be suffering reimbursement. That could be your Christmas bonus. That could mean hiring additional clinicians so you're not working a significant caseload and doing 5 starter cares in a day. So it's essential that you get that training, in my particular opinion. Here are a couple resources that you can use to get additional information about Oasis and how to answer questions. The very first site here is Understanding the Oasis C Guidance. If these URLs, the web addresses, are too small on the slides that were distributed to you, please email me and I'll get that information to you. But this is a CGS Medicare website. I found it as a one-stop source for a lot of different areas. So I encourage it. Even if you're not CGS, you're covered by Medicare, and CGS is one of the contractors for Medicare. They all have the same Oasis guidelines. This is a link to training that is beneficial to you. It's the full Chapter 3 guidance manual. In that guidance manual, it gives you a detailed listing of every Oasis question, the intent of the question, which is what they're trying to ask by that question. It gives you the time points that should be assessed, as well as additional information, bullet points that is response-specific information for you. And those response-specific information, hand in hand with the intent, is what helps you understand, is this a 2 or is this a 3? Again, I'll say that it is never a guess match or a coin flip. This patient could be a 2 or it could be a 3. If you understand the guidance, the response-specific instructions, the Q&A, you'll understand every single time it's a one or the other choice, not an either choice. The Q&As, as I mentioned, come out on a quarterly basis. The second site here allows you to continually look at those. They typically come around the 20th to the 18th to the 21st, usually, of the month as far as when they're released. It's every quarter, so they come out in March, and they come out in June, and they come out in, no, I've got my months off. Yes, March and June and October and January is when they come out. So, but it's essential that you look for those because they give you continued updating on unique scenarios and sometimes change. The last year of Q&As gave significant information about face-to-face changes, how to make those. The most significant release that came out this past quarter is the fall risk assessment. We'll talk about that more towards the end of the Oasis section of this webinar. But the purpose is to help you understand how to answer those questions. And then the very last one is a lot of clinicians aren't aware that they can ask questions to CMS when you have a unique scenario. Unfortunately, I don't believe those questions are answered in a timely manner, but they are the source of the continued Q&As that come out on a quarterly basis. The email address is on the screen to where you can ask a question if you lack understanding of how to answer an Oasis question, or this is a unique scenario that doesn't exist in the current Q&As, and you truly don't know how to answer a question, or you're discussing patient's case or potentials as you're learning Oasis and a thought occurs to you, by all means email CMS, and that will be potentially be addressed in the next Q&A. So those are some resources. Again, if you can't see those on your slide you have in front of you, feel free to, hopefully I've talked long enough, you've had a chance to write those down. If not, email me and I can give you those links and tell you where to find those at. Use the Oasis Coordinators, which is one of the sources you'll find when you go out to that CGS website. The Oasis Coordinators are government-paid employees that will help you learn how to electronically submit your data. They'll provide you training on that if you don't already know how to do it, or you want to train more people on how to do it the right way. They'll give you specific instruction on why you received an Oasis rejection message and how you can correct that. There's a lot of agencies that call us saying, you know, my Oasis got rejected because a common one is there's no primary diagnosis code. When we look at the Oasis, we find out that, and this only affects some states, but there we find out that they used a HIV or an AIDS diagnosis as their primary diagnosis code. And certain states, and there's I'm going to guess there's about 12 to 16 of those that automatically, as a privacy policy, remove that code from the primary diagnosis before they analyze the Oasis data. So in that process, they're stripping out that HIV code in the submission process so that they adhere to that state's policy rules. And when the actual validation rules get run on the Oasis, now the observation is that you have no primary diagnosis. When you look at your Synergy software, you look at your assessment, you see that HIV code, so you're left scratching your head. Why am I getting a rejection? Because this is there. Our clinicians, I'm sorry, not our clinicians, our QA staff, support staff, can go in and look at your assessment that you submitted, and they'll say, yeah, I'm confused as you are. There is a primary diagnosis code there. But it's the Oasis coordinators that can provide you with information about that, be able to give you understanding of the errors. I didn't list it on this site because I didn't think about it till now, but there is a website called qtso.com that you can use. It actually gives you a PDF document of all of the warnings and errors that you receive, as well as the corrective action of what you should do. So when you're receiving an Oasis validation report back from your submission, you can consult that errors list, and it'll tell you why you received it, or at least give you an idea of why you received it, and it'll give you the detailed information on how to correct that. If, in case you didn't have paper and pencil ready the first time, I'll give you that website again. It's www.q, as in Quebec, T as in Tom, S as in Sam, O as in Oscar.com, qtso.com. So that can also be a source of the Q&As that I referenced also. It is a CMS paid contractor site that gives you information about Oasis. When things change, the Q&As, that you can also get the Chapter 3 guidance from that site as well. The other thing that the Oasis coordinators can do is they can answer specific technical related questions about the Oasis submission process. You're having problems connecting to the site, your password's not working, they can reset your password and so on. This is a PDF document at the very bottom. Again, it's all supposed to be one line. I wanted to make it as big as possible for you to read it. So as you're typing this particular document name into your internet browser, you want it all on one line. So where it ends on the right side of the screen, initiatives, dash patient, dash assessment, dash, you should immediately put, without any other spaces, instruments, / Oasis, and so on. If that's too small for you to read on your handouts, again, let me know, and I can email that to you so you have information about that. But each and every state has an Oasis coordinator that you can contact, and their whole purpose is to answer your specific Oasis submission questions, and then the errors that may result and so on. This next slide looks very similar to the other. You might not even notice that it changed. These are your Oasis Educational coordinators, and these should become the best friends of your clinicians out in the field. Their purpose is to train on Oasis data administration of the assessment, give you tips and guidance on how to do an Oasis assessment, things that the clinician should be looking for. They provide technical support on integrating the Oasis in your documentation. One of the conditions of Oasis, and it's been put in the conditions of participation, I'm pretty certain, is that you have to have a comprehensive Oasis assessment. You cannot have Oasis questions and then another clinical assessment of the patient. It has to be integrated in one full document. But the purpose of the Oasis Educational coordinators is to help you understand that. And they give you guidance on how to do that. They'll answer your detailed questions, clinical-based questions. The other side of that is they can answer specific questions that you have regarding the patient's scenario. The support staff at Synergy, when you call in and you ask a question, they're not trained in Oasis. They're not clinicians. They're not legally able to answer your questions because of the liability issue that would present to Synergy. The Oasis Educational coordinators would be the source to where you could go and get your questions answered. You know, I have a patient here that can ambulate with a walker, but I'm really concerned because of a knee replacement. They're not safe in doing that. How would you suggest I answer the question? And they're able, the Oasis Educational coordinators, as they are able to answer those specific questions you have. In the past, and I don't know that they currently do this, you'll have to contact them. In the past, they have done regional training for agencies. So you could go to, I know that we sponsored an event back in 2006 timeframe, I think, to where we sponsored in the Los Angeles area for an Oasis Educational coordinator to come down and speak at one of our workshops. The URL, how to contact them, is at the bottom of your screen. Again, it's supposed to be one full line typed in your web browser. So again, at the bottom where it says assessments hyphen, go to the second line, it's instruments, all one line without spaces or other punctuation except for what's shown. There is an educational coordinator for each state. It lists the email address as well as the phone number for those individuals in case you're not already aware of it. So it eliminates the guesswork in completing the assessment. Now I want to move into answering these 5 questions and help you understand the commonly misunderstood questions. Some of these are Casemix questions, some of them aren't. When a surveyor comes out and looks at your data, when an Oasis, when you submit your Oasis, let me back up a second, when you submit your Oasis data to the state, all of this information is provided to the surveyors. So when you get warnings, not to scare you, just to make sure you're aware of this, when you get warnings that your Oasis is being submitted out of timeline, what that means is you completed a recertification early or late. You failed to do a transfer, you submitted a resumption of care, and now you saw that you missed the transfer, so now you're completing it. All of that information is given to the surveyors, and they have access to that. So that could be a topic of discussion at your next survey if you have issues there. If you're submitting your Oasis data after the specified 30-day period, those are all concerns that you want to address because while I've never been through a survey, I've talked to agencies that have been, obviously, and no one wants the surveyor to spend any more time at the agency than what they have to. They don't want to open up any more potential questions for the surveyors or areas of scrutiny. So some of these questions we're going to talk about now will help you not only in accurately understanding the Oasis questions, but hopefully understanding how to answer them, why you need to answer them or assess the questions, and some of them are Casemix related questions that can determine additional reimbursement for you. So let's go to the first one, M102 and 104. A lot of agencies that we do reviews for will put in the same date in both of these questions, or they'll put in the referral date in 102. The purpose of these two questions, and they're really exclusive of one another, is to determine with 102, was a specific start of care date ordered by the doctor? In the vast majority of cases, there is no specific start of care date ordered. The doctor doesn't give you a referral and say, for the vast majority, they do say this, they don't give you a referral and say, my patient's on antibiotics, he just had a knee replacement, you must go see them today. You know, in those few patients that applies to, they will say that. But they don't say, here's a referral, go see him today. A vast majority of the time, you have your 48 hours as prescribed in the conditions of participation to go see the patient. They're just giving you a referral as a prospective client. In those situations, you would answer in A, in 102, that there is no specific start of care date ordered. And then you would answer the actual referral date in 104. Occasionally, you get a referral that we're planning on discharging the patient tomorrow or today, and for whatever reason they get bad lab results that they decide we're going to keep the patient for another day or two, and they give you a second update or a referral on the fact that the patient's staying in the hospital, we're going to discharge him in 3 days from now, whatever it happens to be. Unless there's a specific start of care date ordered, which is seldom, you would always mark in A on 102, and then in 104 you would use the latest date with updated information provided to you. So if you're given a referral on a patient that's supposed to be discharged on October 1st, and for whatever reason they don't get discharged from the hospital, you don't use that October 1st referral date, you use October 3rd, now we're actually discharging the patient. Here's a new update for you, we're discharging the patient. You would use October 3rd. The most recent referral date or updated information would be the date used. But you should never put a date in both of those boxes. Living arrangements. M1100 is another very frequently misunderstood question that if you don't read the item intent or if you don't read the response-specific instructions on how to answer this question, or you've not been to training, then chances are you're answering this question incorrectly. A lot of people will look at this question and they read the title question saying patient living situation. Which of the following best describes the patient's residential circumstances and availability of assistance? So they go down and they say, well, this patient has their daughter living with them, so I'm going to answer row B, and she lives with them 100% of the time, so I'm going to say around the clock. The way this question is intended to be answered when you read the item intent, which is what I have at the bottom, is that you answer based on the clinician's professional judgment, whether the patient is living alone or with others, as the first. So you answer the living arrangement to determine the row. Is this patient living with somebody else? Are they living in a community-gated or a congregated situation? Or do they live totally alone? Then once you know that, you know your options for answering the availability of assistance. How frequently is somebody available to provide assistance to this patient? So it's not based on how often do they have somebody else living with them. It's based on whether or not they have assistance available during that period. Assistance available means that somebody is physically in the house during the assistance availability answer choice. So if one or more people are in the house 24 hours a day, 7 days a week, you can safely mark around the clock. If they're there to assist them ambulate, prepare meals, do wound dressing, help them at their other ADLs, then that's the appropriate answer. If they live with a wife, but the wife goes to work, she's not available during either regular or daytime hours or regular nighttime hours because of her shift, and there's not somebody that comes in to assist in the facility, then you cannot answer around the clock. But you must then go to the next best answer. If the wife works at night and she's home during the rest of the time, or has somebody come and fill in for her, then you answer regular daytime. If they work during the day and they're home at night, then you can answer regular nighttime. If you don't have continuous coverage every day of the week, the guidance for this particular question says that occasional or short-term assistance is available, or possibly your patient has no assistance because they're a hermit, they don't have anybody that comes and checks on them, and so on. But it's essential that you understand this because this question helps document the homebound status or the need for services. If they don't have any assistance or they only have assistance at nighttime, there's a large potential most people are up during the day. So there's a big chance that they're going to fall and they won't get the assistance they need. They won't get the bathing they need. They won't get the wound care or the medication assistance. So this is really essential in answering your documentation. This is not a Casemix question, but every question is important, otherwise it wouldn't be asked. The other thing that's important to know about this question is the living situation is supposed to be the living situation based on what is the new norm for this patient. So if the daughter or a son has come to live with the patient for a short time because of the illness and they're going to go home, or maybe dad came home because of the illness, is now living with the daughter until the knee replacement is healed, until the therapy is resolved, and then he's going to go back to living alone, this question is answered based on the normal situation for the patient, or the new normal. If they're no longer going to go home, it's decided that dad can't go home because of the level of dementia, he has to stay with us. Then that's how you decide the living arrangement. It's not a situation that the patient lives with another because for the next 60 days they're living with the daughter, but they normally live home. So that's some information about this question. 1200 is another question that's frequently misunderstood. The question specifically is asking about the vision of the patient. Now I want to focus here at the bottom of the slide because you have to understand the intent of this item to be able to correctly answer it. This identifies the patient's ability to see and visually manage or function safely within his or her environment, wearing corrective lenses if they are normally worn. There are a large number of agencies or clinicians that answer partially impaired because they have glasses. That's not the intent of this question at all. Likewise, and I may get some flack from this, there are a lot of patients that maybe have limited eyesight in one or the other eye. The clinical, and this is one of those areas where Oasis does not make common sense. If you have glasses that you have to wear, the typical person would say, yes, that patient has partial vision impairment. Without glasses, they couldn't see. The fact that they have glasses corrects that, and it's no longer an issue. If they're partially blind and they have blindness in one eye or the other, but they can see fine in the other eye, that is the normal operating circumstances for them. Why you're going to answer that, and you would do a poll out on the street, is a patient with blindness in one eye partially impaired? The answer would be yes. For Oasis purposes, a patient that is blind in one eye but has normal eyesight in the other can safely function function safely in their environment. So the Oasis guidance indicates that even if a patient's blind in one eye, they're not partially impaired. This more speaks to the fact that they have glasses, but they're out of date, they're blurry, they can't read prescriptions, they can't see tripping hazards such as cords. That would be a problem. They have a neck brace due to a cervical fusion of the vertebrae. They can't safely turn their head or bend their neck to be able to see obstructions. That patient has partial impairment because they're no longer safe in their current situation. So again, this helps deliver, while it's not a Casemix question, it helps deliver need of skilled services and homebound status. 1800 to 1890, your ADL, your IADL questions, a lot of people answer this incorrectly. The two important things to know, well, there's three that I put on the screen here, is that what is the patient's normal status 50% or more of the time? A patient may have a wheelchair, they may have a walker, they may have a cane. What do they use 50% of the time? Do they use the wheelchair just for long distances when you go walk around the block? But 90% of the time they're walking with a walker in the house. That would be how you answer this question. A big area of these questions is don't assume that they're able to use an assistive device. Physically ask them to demonstrate it to you. So when you're getting to the bathing questions, don't assume that they can use a back scrubber without being able to see them demonstrate that to you, because if so, you may be making an incorrect assumption. They're not able to thoroughly wash all of their body without assistance, but you incorrectly assume that sure they can use that assistive device. Who can't use a back scrubber? So you're answering those questions with assumptions which may be wrong, and the ADL questions are all Casemix questions, and they do impact your reimbursement. If you make an incorrect assumption, then you could be denying your agency reimbursement that they need. The other question is that commonly is how this question is answered is the patient has a walker. They use the walker to get from the couch to the kitchen when I ask them for a drink of water. Therefore, I'm going to answer this as a walker. But the question intent is, are they able to do it safely? And I apologize. I wanted to put safety up there. I guess I emphasized safety at the top. I didn't put it on that first bullet. This question specifically in the response-specific instructions states this question does not consider the willingness or compliance of the patient in answering this question. So the fact that a patient is ordered to use a walker but instead uses a cane because the walker makes them look old or something, that should not be how you answer this question. You instead answer it based on the willingness of the patient, the safety of the patient. What does the patient need to be doing, regardless of what they're currently doing, to be safe? Do they need assistance when ambulating because they just had a knee replacement or a hip replacement and they're unstable? Do they have muscle weakness because they've been in a rest facility because of a fracture of a femur and they're not stable to walk on their feet? Regardless of the fact that they do walk with a walker, are they safe to do it? This again speaks to homebound status and needs of skilled services. And making assumptions, answering these questions without knowing the intent or the response-specific guidance can lead you to answering these incorrectly and lower your reimbursement significantly to pay for that therapy and other needs than what you would otherwise. The last question here in the Oasis area is M1910, the fall risk assessment. This question is asking, are you using multifactorial assessment techniques? Are you looking at medication? Are you looking at their ability to ambulate? Are you looking at rugs and such? But to answer this question as a yes, which is a 1 or a 2, the item intent and the response-specific instructions specifically state that you must be using at least one of those multifactorial assessment tools that is standardized and validated. CMS has, in Chapter 5 of the Oasis Guidance, a few of the areas that you can use that are standardized and factorial. They won't dictate which one you use. It's totally up to you. But when a surveyor sees you answering yes, and they look at this chart and they say, no, you didn't use that, they can change this answer and potentially put the claim at risk. The two standardized and validated assessments is your TUG and the Mach 10. I strongly encourage you to look at the Mach 10 and utilize it if you're not currently using something. And I'll tell you why in the next slide. But the URL is listed for you in green. Again, it's small print, so if you can't see that, please let me know, and I'll give you information to those. But they're at the website to where you can get information on how to use these. Now, the next slide here, I may get a lot of flack as well because it's contradictory to common sense. Oasis is asking, is the patient a fall risk? Now, you're going to look at a patient and oftentimes say, yes, they're a fall risk. They've got issues in their house. They're incontinent. They have rugs on the floor. They've got cords and trip hazards. But Oasis, for this specific question, 1910, doesn't care about any of those if you didn't use a standardized, validated tool. Another area is non-ambulatory patients are a fall risk because they can't support themselves if they were to get up, or if they lean forward, they may not be able to stop themselves. So you may want to answer yes, that this patient's a fall risk. But Oasis, again, is looking, is it a standardized, validated tool that you used? Or is it just something you concocted in the back room or based on your clinical experience? Oasis guidance for this question says if the patient's non-ambulatory, you have to score 0 if you're using a TUG. If the patient's too tired to participate in the process, unless you go back within your 5-day period, again, you have to answer 0. You can't assume that they are or they're not a fall risk without using the standardized validated tool. And the guidance for that is in the center of the screen. Select response 0 if a standard validated multi-fact risk tool was not conducted by the home health agency. So that's the guidance in the response specific for this question. I'll let you read the others. But why I encourage the Mach 10 is it does allow you to answer yes, 1 or 2, to this question, even for non-ambulatory patients. The Mach 10 was validated and I believe it was it was October or maybe early November, but it's a very, very latest change. And actually it was October because it's in the latest release. So the Mach 10 is a tool that I would encourage you to look up and use. It's about 6 or 8 questions. It is a standard validated tool, and 1910 is one of your process measure questions that's reflected on Home Health Compare. How many agencies are conducting a fall risk assessment for their patients? And this allows you to answer yes to every single patient if you're answering those 6 or 8 questions contained in the Mach 10. These are some fall risk guidance that's available to you. This was taken out of Chapter 5 of the Oasis Manual. It's telling you that the fall risk assessment or the TUG test, sources for those, where you can get information of those. But the top one is the Mach 10. The Missouri Alliance of Home Care is MAHC, the Mach, and in version 10 of that, I'm assuming maybe 2010 is when it came out. But the Mach 10 is a valid tool. This is the latest updates for Chapter 5. So look at those. I want to end this by talking about coding. Coding guidelines come out frequently. They don't come out every year, but they're always effective October 1st. They define the rules that you have to use when doing your ICD-9 coding. There are different coding guidelines for ICD-10. You may want to start looking at those if you're not already. Coding guidelines change almost every year with releasing new codes. deleting old codes that you've used in the past, or changing the description of a particular code. So then, as I say at the top, the numbers really do matter when you're answering your ICD-9 questions and you're doing your coding. So I want to show you where you can get those coding guidelines at. Specifically, as the top one is the PDF for the latest coding guidelines. Even though they came out in 2011, there's not been a change to those, so they're still effective for this current year until new ones come out. The coding changes, the website you can go to every single year to see what those coding changes were, whether there are new codes, whether there are deleted codes that are no longer valid. I encourage you strongly, I can't encourage this enough, purchase a new coding book each and every year because new codes come out. There are the 3 coding books vendors for home health agencies. I strongly encourage Decision Health strictly because it's the one I'm most familiar with. That's the one that I'm certified through for coding purposes. But in the book, it gives you a lot of coding tips as you're going through to prevent you from using inaccurate codes. Nginx may have similar functionality. I've not used it. And PMIC is the silver book that a lot of coders reference. I'll be quite honest, the Decision Health is the most expensive, with Nginx being the second most. PMIC is the least expensive. I've never used the PMIC, so I can't say which benefits it has. The Nginx is similar. Most of the coding guidebooks are now giving you ICD-9 and ICD-10 codes or crosswalks in between the codes. But because of the coding tips available in Decision Health, that's the one I encourage you to use the most frequently because it gives you guidance of when to use codes or when not to use codes. Again, those acute codes I mentioned, a CVA. You can code in home health late effects of a CVA, but you can't code an active CVA because those are being treated in the hospital or in the acute care facility. You can't code fractures because that treatment is done in the acute care facility. You can code fractures in 1024 as a resolved case or one that's being resolved as your payment code, but in home health you would code the aftercare for a fracture. But Decision Health gives you coding tips for that. I encourage you to look at it. You can buy the manual or you can buy an online interactive tool that gives you functionality as well. As far as coding, there's 5 comorbidities that I strongly feel and many in the industry feel that you should be coding each and every time, even if they are stable. And this is a very important reason why to look at the H&P for the patient. Don't just take the referral because the patient says, I need you to see this patient because of a knee replacement. Ask them for an H&P. Call the patient's primary physician and ask for an H&P for the patient. I know it's difficult. Some of the agencies we work for, it's difficult. But without this document, you are denying yourself potential reimbursement. The 5 codes that you should always consider coding are COPD, CHF, CAD, diabetes, and hypertension, even if they're stable. Now, the question that a lot of agencies ask is, by putting those on, am I upcoding? And the big response is, if you don't have interventions to assess and monitor those throughout the assessment, you are upcoding and you should not code them. The reason you put them on, even if they're stable, is because SCICs are no longer paid. A SCIC is, if you're new to home health, a SCIC is a significant change in condition. Up until 2010, CMS would change your reimbursement and increase or decrease it based on the change in the patient's condition. They were being seen for hip fracture. They had an exacerbation of CHF. They went in the hospital. They resolved their issues, their oxygenation and breathing treatments and so on. They came back to you. Now, because they have an exacerbated CHF, you're monitoring that, your payment goes up. Unfortunately, in 2010, CMS said, nope, we're not paying for SCICs anymore. So the only reimbursement you get is at the start of care episode or a recertification 60 days later. If the patient has an exacerbation at any one of these, and COPD, CHF could easily exacerbate very easily. Hypertension could become uncontrolled, and you're having to go out for multiple visits. Diabetes, they have potentials with circulation and wound care and so on. Uncontrolled blood sugar, all of those could have big issues. With CAD, their heartbeat and heart rate could change and so on. So if you choose not to code these, then you're denying your agency any possible additional reimbursement until the next episode if the patient stays on. So that's why it's strongly encouraged to add these, because they can fluctuate so easily. As long as, and I put it in capitals, the agency must assess and monitor. You must have interventions on your 45 to assess these. If you don't, then you are guilty of upcoding and Medicare fraud and potential penalties that come from that, because you're observing the patient has an issue and you're just not doing anything with it. You're collecting the money for it. As long as you've got interventions to monitor the pulse ox of the patient, you've got weight gain or weight checks for your CHF patients and so on, to be able to put those on. Now, I will say with hypertension, 401, as you may know, is no longer a Casemix code, but 402, 403, and 404 are. So you want to look at those manifestations to see if you can use that additional code instead. COPD, 496 is the default COPD, and this is another reason why you must ask for those H&Ps or clarify with the doctor. Is 496 is the code, default code for COPD. It is not a Casemix code. But if you can confirm with the doctor that the source of COPD is asthma or bronchitis, chronic bronchitis, or emphysema, then those become a Casemix code, and that means extra money for the agency. So it's important that you ask those questions and be able to monitor that. This is covering SCICs. I already talked about upcoding, so I'll just kind of skip this slide. You can look at it some more. Using the manual itself, it's super important that you don't use a lot of the apps for your final coding. The apps that you can download and use on your iPhone, on your Android phone, and so on are great tools to give you and help you focus in on the diagnosis code, but they do not have the coding tips and the instruction and the guidance that the coding manual will have. So you may be using a code and not be aware, because the app doesn't tell you there's a manifestation code you have to use also. They don't have the exclusion and inclusion notes. So I strongly encourage, as strongly as possible, that you use a coding book and you update that every year, because the alpha index is going to help you find the code you should use. You should never stop there. You should always go to the tabular index, which is volume 1. That's where your codes are listed. And look for those exclusion notes or those inclusion notes. Look to see if there's coding tips that tell you when you should use this code or when you should not. Look to see if there's additional manifestation codes you should use. So that's super important. I want to end with the next few slides talking about manifestation codes. When a disease or a condition exists that has other manifestations of the code is when you're going to use those. According to the guidelines, certain manifestation codes must be preceded by a code. An example of that is PFD with manifestation is a manifestation of diabetes, and there's certain sequencing or orders that those codes have to be in. The coding guidelines give you instruction on that. That 107-page document I referenced, as well as your coding books, are all going to tell you when a manifestation code must be used, and you have to put those in the sequencing. Sometimes they're put in 1024 if it's a V code, not all the time. One of the things I didn't put in this slide, I apologize for that, but one of the things that I would encourage you to do, there's a lot of agencies that choose to use 1024 as a justification why they're doing aftercare. Appendix D of the Oasis Guidance Manual, which I referenced earlier in the slideshow, gives you instruction about when you're supposed to use 1024. There are a lot of agencies that put in a justification for a V code, not following 1024 guidance correctly, and that's one of the reasons why in 2013, January 1st, agencies can only get paid for fracture codes put in 1024 because they were using 1024 incorrectly. So in January 1st, 2013, if you haven't heard before, you're only going to get paid for diagnosis codes that are fracture codes. You won't get paid for resolved conditions. You're seeing a patient for aftercare due to a knee or a hip replacement. Typically, you would put your primary code as aftercare of a joint replacement. You would list 715 in your 1024 for Casemix points and so on. They're changing the coding sequence that you should use. I don't have time to talk about that in this particular webinar, but I can discuss that with you individually if you'd like. Maybe we'll be putting another webinar together to cover that if you don't already have that. Manifestation coding conventions that you'll see when you look in the diagnosis code book are going to be brackets after those. The slide kind of gives you detail of when you would use those manifestation codes and some examples of due to or with to focus on that documentation. So I won't cover that a lot because of the time. I want to leave it an opportunity to ask some questions. Etiology is a code first, must immediately be followed by the manifestation code. You can't put in that the patient has diabetic related renal issues and put diabetes as your top and then put below that somewhere farther down CKD because it's not a Casemix code. They have to follow one another. You can't say my primary diagnosis code is CKD and farther down list 250.60 because I'm seeing this patient. You have to specify those immediately above one another. If the manifestation is due to an etiology, you have to put the etiology first and the manifestation below that. Otherwise, you're not following those codes. And you're going to see that in your coding books because it's going to say use an additional code, code first, underlying disease, as you're going for that. One of the things that you will see is code first does not mean you have to code it as your primary. Common manifestation examples are hypertension with chronic kidney disease. Look for that because hypertension itself is not a Casemix code. When it's related to chronic kidney disease or it's related to heart failure or heart disease, then that becomes a 402 or a 403 code or a 404 if they're all three together. And those are Casemix codes, which mean extra reimbursement. Diabetes manifestations listed, sepsis, are all manifestation codes or multiple codes that are requirements that you have to look for. Thank you very much for your time. I'm going to look and see if there's any questions to be answered. My information is on the screen if you want to give us a call specifically to me or email me. I'll say my email address in case you didn't get the slides because on the screen here it's not very clear at all and I could not change the font color from green. I don't know why it chose that. My email address is michael.tid@healthcaresynergy.com. And I'll go over that, spelling it out for you. Michael, M-I-C-H-A-E-L, with a period. Last name is Tidd, T as in Tom, I as in Indigo, D as in David, D as in David, T-I-D-D, at healthcaresynergy.com if you have specific questions or a question arises after this presentation. So I want to look and see, I don't see any chat options here. Let's see if there's questions. There are some questions, so let me scroll up to those. See if there's a way of making this bigger, and it's not. Oh, there is a way to make it bigger. Let's go for it. I've got my technical advisor. Oh, excellent. Yeah, see quick poll only. So that was a question. We changed that. Where is the webinar? The only screen I have is the poll. Sorry, resolved that. Oh, down at the bottom. Can you speak about 1024? Yes, 1024 is your payment diagnosis coding. When you use 1020 and 1022, that's your primary and secondary codes. 1024 are additional codes that are only supposed to be used when they're currently, now I'm not speaking of 2013 right now because those rules change, but currently, and keep in mind, you can go back and review some of your coding for the prior year and make your timely billing changes up to a 12-month period from the end of your your episodes. But 1024 is your additional payment codes. There are times that you must use a V code as your primary. A big example of that is when you're doing a therapy-only case. And it may be because of abnormality of gait. It could be because of a knee replacement and so on. When you have to use a V code as your primary code, then you're going to want to be able to use those additional codes so that you can get proper case mix. Specifically, there's three categories that pay more when used as a primary, and that is a Skin 1 diagnosis coding group, a Neuro 1, and a diabetes code. So any of those three groups, and there's a large number of codes in those, will pay you more as an agency reimbursement if they're used in a primary code. But when you're doing aftercare for an amputation because of gangrene, you can list the aftercare, but you don't get paid for aftercare. 1024 allows you to get paid for those codes when you list those in 1024 because they're a resolved condition, but that's the reason you're seeing the patient. In 2013, starting January 1st, those codes cannot be used in 1024 for payment purposes. The new changes with 1024 is that you can only use fracture codes for payment purposes. There will be a significant number of agencies and clinicians that continue to use the 1024 for justification of why they're doing aftercare. That's not correct, but it won't result in a rejection of the Oasis. A lot of your software, Synergy specifically, tell you you shouldn't be using those codes. The other one would be a situation where that's changed in 2013 when the situation still exists, like the gangrene or diabetes or osteomyelitis, and that's the reason you're seeing the patient. You're doing aftercare because of surgical debridement of osteomyelitis, but it's still present, and it's due to diabetes. In the past, you listed those in 1024 to gain your additional reimbursement. So now you're going to choose instead, with the new coding guideline changes or the attachment D information, is you're going to specify your aftercare as your primary. You're going to specify your etiology, which is diabetes, followed by your osteomyelitis in that particular example. Instead of being in 1024, that's instead going to go as your primary. Your secondary B would be your diabetes, and then your secondary C, 1022 now. Just make sure you're clear. The C would be the manifestation of that. So that's now the coding changes so that you get case mix reimbursement for those areas that are still present. Can you recommend coding classes online or in person? If you email me, I can definitely give you some sources for that. You can do some Google searches as well. The last question I have here, by all means feel free to type in some more. Can we also use V5789 for multiple therapy with skilled nursing? That is a no. V57 is a special code that has to be used if this is a therapy-only case. So V57 point anything can only be used if it's a therapy-only case, whether it's multiple therapies or a single therapy. The fact that you're specifying V57 indicates that there is no skilled nursing or other discipline needs. You're only doing therapy-related services. V57 also must be your primary code. You cannot use V57 towards the very bottom on your 45 because it's not a case mix code. If this is a therapy-only case, then V57.1 if it's therapy services. There's other codes that I don't know off the top of my head, but V57 point something for occupational only, for speech only, or V5789, as the question asks, is a multiple therapy, 2 or more therapy on the case without skilled nursing being involved. A lot of people like to use V57 because it demonstrates a need for therapy. But your other codes and your clinical documentation are going to justify that. So if skilled nursing is in doing disease education, medication management, wound care, you cannot use V57. V57.1 or V57.89, any of those codes, because that's a therapy-only code. What can you use then if there's nursing? Your other codes that you would use would dictate the disease process, the reason you're seeing the patient. If there's nursing and you're trying to justify the use of therapy, you would use the disease process or the issues of why therapy is involved. Typically, you're going to have abnormality of gait, hip replacement itself, you're going to have difficulty in walking, would be those additional diagnosis codes that you would use. But unfortunately, V57, if you read the actual content of it, has to be used as primary in the coding guidelines specifically if it's a therapy-only case. And then you would not use that if it's other skilled services. What are you saying that you can't use V57 in the lower codes? V58.81, V57XX. In the coding guidelines, it states that V57 is a therapy-only item. Let me see if I can find that real quick in my coding book of where you reference that, and I can tell you where to look at that. I'm not positive. I'm going to find it really quick, but I can email it to you if you'd like. But V57 in the coding guidelines specifically is where you're looking for, and it is a primary code only as the choices, so it can't be used in any other location besides the primary code. But I'm not finding it immediately. Oops, and I've got a whole bunch of other codes and questions that popped up. Email me on that, and I can give you the exact coding reference of where it says you can't use 57 in a lower position, why it has to be primary. Another question is, what should be the answer to 2250C if patient refused PT through diagnosis only is late effective as CVA? 2250 is one of your process measure questions, and it is addressing whether or not interventions appear on the care plan as a result of a limited number of issues. Is the patient diabetic, and do they have foot care? If, because the patient themselves may refuse therapy, but you may put those interventions on the care plan, but your answer would be based on whether those interventions are needed and whether they're on the care plan, even if the patient refused. So when you're looking at the specific question is what should be the answer to C is if the physician refuses to put therapy on the care plan due to fall risk or other things, then you would answer in A, or you'd answer in O for no. If it's needed, then and it's not on the care plan, your only option is no. If it's not needed because the patient doesn't have, an example would be pressure ulcers, they don't have a risk of pressure ulcers, then you can safely say in A because it's not needed. Or you can say yes, that they're on the intervention because that's our policy as agency anyway, is we're always going to monitor and teach about pressure ulcers. So the specific question is, what would be the answer to 2250C if patient refused PT, though the primary diagnosis is a late effective as CVA? The question that I'd ask you back would be, is or are there interventions on the care plan to address that? Because that's what the question is asking, not is does the patient accept therapy services for late effects of a CVA, but instead do you have interventions on the care plan to address that issue? So the question is, are there interventions? If there are no interventions and there is a fall risk for the patient, then you would have to answer no. If there are no interventions and there is not a need for that, then you can answer an A. But late effective as CVA more than likely is putting the patient at a fall risk. So your answer would be yes, if there are interventions present, even if they're not carried out because the patient refused services, because it's a process measure that is being asked. Please do I have, please do, oh, okay, as far as emailing V57, the statement. Can you use gait abnormality and difficulty walking as a primary diagnosis? You can, if that's the sole reason you're in. There is not a reason. Let me double check that, because your diagnosis code book will tell you whether or not they can be used as primary, and I try not to memorize codes as much as looking them up in the book, because I want to make sure that I see those scenarios and those coding tips and guidelines every single time I'm using a code. So I want to make sure of those. Difficulty in walking could be used as a primary or a secondary code. There's no restrictions on that if that's the reason you're in, and that's oftentimes is justification of therapy services. 728.71, 28.82. Muscle weakness could be used as a primary or a secondary code. And abnormality gait, I know, can be used as a primary or secondary code. So yes, you could use those as primary if that's the reason you're seeing the patient, unless it's a therapy-only case. In that case, you would have to use V57 as your primary code and follow that by abnormality of walking. But if this is a skilled nursing and PT case, then you could use difficulty in walking if that's your primary need. Say the patient has difficulty in walking, they're sitting in their chair a lot. As a result of it, they developed a pressure ulcer on their buttocks or another area of their body. So you have skilled nursing in the case, and you have therapy. And the primary reason is therapy. You're treating the wound, but you're in there to do therapy. So that could be your primary reason and the source or the result of that. And it's not a it's not a therapy-only case. You could use difficulty in walking as your primary, if that's the justification of why you're in. Skilled nursing would be in as a secondary and be able to walk out. Question here is 781.2 primary and B57.1 in that order. Unfortunately, I'd have to disagree with you in the coding guidelines require that B57.1 be the primary code. And I will look that up and email that to you as far as where that's at, because I don't know that off the top of my head. But everybody who wants that, please let me know and I'll forward that to you. I can't find the coding guideline off the top of my head right now. And unfortunately, there's another webinar going after me as well. But email me at michael.tidd, T-I-D-D, at healthcaresynergy.com, and I will give you the exact coding guideline reference of where that's at. The V57.1 has to be primary. Again, if you're using the coding guidelines and the coding manual, it's going to tell you that information. If you're using the codes and not following the coding guidelines, CMS is not going to kick back your claim. They'll accept it and they'll pay it. But these are the reasons why you're seeing a lot of significant changes in Oasis and CMS and such as a result of incorrect coding guidelines or coding use. And that's a big reason why we see so many audits and ADRs, because people aren't using the training and education they need in the codings. But with that, I want to thank you for attending. I hope it's been very beneficial to you. Please email me with any other questions that you may have. I'll respond to all of those and respond to those with coding guidelines or specifics on why those are the needed answers, so that you have that for justification in the future. Thank you very much for your time. I appreciate it. Hope it's been very beneficial to you. I'd love to hear back from you at michael.tidd@healthcaresynergy.com if you found this beneficial and if you would like more webinars towards these kind of topics. Thank you very much. I appreciate it. You have a wonderful day. Bye.
For your